COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities. This is the last meeting before September. COIN habitually meets every month, the last week of the month, excepting 3 times a year, that's Easter, Christmas and the August holiday. And it doesn't always mean that we finish our kind of theme at that in July, but kind of this year we sort of have. We spent the last year and a bit putting all our efforts towards influencing the UK NHS 10-year plan, and we've sort of got to that place and been relatively successful.
Hi, I'm John. I am currently working primarily in social care as a consultant. I'm a director of a care association, so doing lots of interesting stuff around putting together an event around social care innovation, thinking about the case review and what that might mean for us, and then lots of quite tedious stuff like renegotiating contracts for fee uplifts and trying to make sure we can pay staff for various things. My background is I was a senior manager in Marie Curie, and I've been chief exec of a couple of VCSE infrastructure organisations and sort of spent a long time around, I guess, the interface of communities and health and social care and sort of deprivation and inequality in various project forms.
And on Tuesday, that really helped fuel a discussion on the table about carers, which we divided into carers who are unpaid, unexpected, untrained, living at home, and professional carers who are expected to do things whatever people think without actually necessarily having the language. And we talked about how the community health and wellbeing workers, that led by Matt Harris and Connie Youngens, might become a role to talk about professional carers, people who go from house to house helping people to help themselves, rather than people going house to house telling people what to do, which is the traditional model. So
my name is Duke Tran, yes, and I am a qualified social worker. I've been qualified for over 23 years, from Australia initially. I've been practicing in the UK for many years as a frontline practitioner, but also as a manager, and more recently have been involved in program design and development. Currently, I'm in adult social care in Brent, and I'm a transformation program manager. I work in co-production and community partnership, and also using digital as well. So
I'm a retired GP in Brent and still living in the borough. I am involved in a campaign to get Brent to sign up to be an age-friendly borough. I'm chair of Age UK London, which campaigns for an age-friendly London. We don't provide services, we just campaign. And I've been around COIN slightly on the periphery for a while, but I've really enjoyed the conference 2 days ago. Lots of food for thought and thinking about how we take our work forward.
I guess I'm going to Brazil for COP30, which says something about my career as an intergenerational neurologist. So I am trained in neurology and geriatrics, but work a lot on climate and health. And hopefully Brazil will do a better job of bringing COP30 to some degree of sanity, which they have not yet been able to achieve.
Hi, everybody. Nice to be back. I wasn't present at all of the conference on Tuesday, sadly, but what I was there for was very energizing, interesting, eclectic, as ever. I'm a GP too, and I teach ethics in various places around London and also in Malta.
Is going to carry on doing monthly meetings or events, mostly by Zoom like we're doing now, but also occasionally face-to-face like we did a couple of days ago, which will be videoed. So Tuesday was videoed and it will translate into a film. That film will then be logged on the COIN YouTube channel, and from this a blog of something like 700 words will be extracted, which the two of them together, the video and the blog, will document the ongoing discussion between different parts of COIN, because COIN members are all over the place. I described them as butterflies the other day, with different backyards, each rather inoffensive to other people, but quite colourful, and also just a little bit resistant, unhappy with insecticides, which there's quite a few around. As well as that, we will make from some of these 2,000 word essays that will be chapters in a web-based book. Camilla Hawthorne, the present chair of the RCGP, is standing down naturally at the end of her time in November, and she's a great friend and wants to carry on the connection, the close connection with COIN through her new role as chair of the National Academy for Social Prescribing, which is potentially very good. And stepping into her shoes is our favourite candidate and a long-standing COIN member, Victoria Georgiou Brown. So there's something rather good going on there.
So I'm Sanjay Gupta. I'm a retired psychiatrist and a fellow of the Faculty of Public Health, and I've been a member of this group for many a year now. I think when we think about climate change, we normally always preface it by talking about global climatic change, which implies that action needs to be at an international and a national level. And of course, that is entirely correct. But now that the focus is so much on action at local and neighborhood level, I think the challenge is going to be to find a way of addressing environmental issues locally as well. For example, through planting of trees, development of green spaces, and so on.
I'm Lucy Kwapsiewicz. My path with COIN crossed when I was looking after, I was working at RCGP, looking after all of the local London faculties, and London Journal of Primary Care was sort of one of my tasks, and that obviously evolved into COIN, and I've just, stuck with the group and supporting it going forward. So looking forward to working with most of you.
A journal that was mentioned twice on Tuesday spontaneously. Matt Harris mentioned London Journal of Primary Care as the first place he published anything about the Brazilian community health and wellbeing workers. And Salman Rawaf, the director of the WHO Coordinating Centre, pointed out how he had argued that the journal shouldn't close. Well, he lost that argument, but there you go.
Brilliant. I thought Matt was really interesting. Everybody was good, but I think to hear some of the detail around the community health and wellbeing workers was, quite interesting. Things like the fact that the workers are fully employed, paid, and that sort of stuff. There was quite a bit of detail, which was really interesting. I'm a commercial lawyer, a special interest in health and social care. I was 24 years at Capsticks, which focuses in that sort of area, and sort of now with my own consultancy.
But my name's Kat, and I'm a PhD student and a GP to be. And I'm right now doing a PhD with a Danish university, also collaborating with Imperial College London. And, well, I guess I got into the thought patterns of the ever-changing healthcare system and what it had become when I was presented with this stark contrast of becoming a doctor and it to be completely controlled by protocol and many other things I thought that it wouldn't be, instead of a human first. And then my path crossed with Paul when I was visiting Imperial College, and we found out that there was in fact this wonderful group of like-minded people for me to join.
COIN's got loads and loads of lurkers who suddenly disappear for a year and then sort of come back. And one of the wonderful things about you is you're here almost all the time. And honestly, I've come to think we couldn't survive without you. So that's fantastic.
Thank you. You're stuck now.
Linda.
Hi, I hope we are stuck, Kat, and would keep you. I really enjoyed I just want to say thanks, Paul. The workshop was really good. I regret I couldn't stay for Laura's, so I'm really happy I'm on tonight so I can hear your talk. It was excellent. It was a really interesting mix of people, very inspiring. and all of the speakers were excellent. So thank you to all of them. My background's education, higher education. I worked in 5 different universities in the UK and also done some research in New York. But my main interest from my background was interprofessional learning and service user proper engagement in higher education of the workforce, healthcare and health and social care workforce of the future. So,
right, retired GP, and then got involved in lots of things in my career. Some popular with the progressive left, and some less popular. But I'll move on. And finished up being the national director, so-called czar for primary care for the English health service, and then retired and doing lots of things. But Paul and I have known each other since Paul was in Liverpool about 30 odd years ago. And we've often shared and developed our thoughts together, which I think is nice now where we're in COIN. And I've always been keen on COIN because when I developed a thing called the Primary Care Home, which was a precursor to what finished up as Primary Care Networks, it was always about a provider organisation. And the fact that COIN wants the public at large and patients to be equal partners is the most exciting thing. That's why I support it so much. Not least because in the practical term, most health services aren't going to cope by just wanting more doctors, nurses and other professionals. Unless we have a more share with the community and with individual patients in a different way than we do now, most health services are going to be unsustainable, I think, in the future. So that's a practical issue. And so I've enjoyed the company. I enjoyed Tuesday, even though I had to come from the far north without a visa. And it was also delightful to meet Lucy and Laura, who I've not actually met face-to-face before. And I also found out, because I chair PCC, the sterling work that Chris Brophy has been doing with them over the years too. So thank you, Chris. And Paul has mentioned that PCC is offering quite a few facilities for us, including possibly even to get meetings which has some money, which some might finish up for us as well, which I find quite helpful, as well as being a repository and a conduit to all sorts of things. So we're building up a nice network, I think, of various organisations, like the Royal College, as Paul has mentioned, and all strength to our elbow. So let's see where we go now. I think we've got an interesting job with the new 10-year plan, which at one sense could be seen as peripheral to us. I've spent a lot of my life trying to grab opportunities, and things like changes like this are often areas when there's uncertainty that people like us should move in and influence at that stage rather than waiting till it's all frozen over. So I think there are opportunities now for us to have some impact with all our friends.
So hi, I'm Laura Calamos. I am a nurse and a nurse practitioner. I started my career in 1992 as a hospice volunteer in the home, and I've been trying to get back to family practice ever since. I did certify as a nurse in North Carolina in 1992. And in the UK, I joined the registry in 2010. So according to being able to teach in the UK, I had to become a nurse in the UK. And that's a lot of why I came to your hallowed halls, is to learn all I could about this funny thing called the National Health Service, which I've been fascinated with my entire career. When I started seeing patients in North Carolina, we had no Affordable Care Act. We had no insurance. The vast majority of my patients were uninsured. And sometimes I'd see a whole family, and they would spend 4 hours trying to prove how poor they were so they could get into the clinic to see me as a nurse practitioner. I am a prescriber as a family nurse practitioner. I diagnose, treat, interpret, much like a GP, with certain caveats, of course, in the UK as an advanced, in the US as an advanced practice nurse. When I came to London in 2009, I was trying to study teamwork in primary care. And there wasn't a lot of literature about that. Multidisciplinary teamwork was really interesting to me. And I was introduced to this strange GP called Paul Thomas, who happened to be doing some really interesting work in the community. And I attached my funded research for knowledge transfer to the South Hall project and had the wonderful opportunity of studying case studies across Northwest London, looking at the transfer of information, knowledge, learning, multidisciplinary teamwork in the community into secondary care and diabetes, mental health, dementia and family services. So I interviewed local authority, attended town hall meetings, and wrote papers with many people in the PCC, PC, and the growing CCGs at the time, and eventually moved on from King's, where I completed my PhD, and on to the University of West London, where I help develop and grow the public health program. So I presented, can you see this okay without the other parts now?
Yeah, it's good.
Good. So I presented at the International Council of Nurses a couple of years ago, and I thought I'd actually start from this, knowing that most of my work was really influenced by watching the South Hall project develop around many of you on the call in the idea of trying to figure out how to grow community-oriented integrated care. I wanted to see integrated services in healthcare because I didn't experience it that way as a nurse or as a nurse practitioner. There were about 10 to 12,000 nurses from all over the globe in Montreal for the presentation. And I really wanted to talk to the experience that many of our patients have and that I think we all have. We work in these silos and there are all these boundaries. And for many of our patients, it's like you constantly hit walls and you can't even see the maze. You don't know why it's not working. You just know that there are these gaps in services and you don't quite get the information you need when you need it, whether you're a prescriber or a patient or a provider, and that these kinds of unintended errors or actual mistakes that are happen because of the lack of connection can really cause huge errors in the service. And so I was really interested in service delivery. And now I have been teaching leadership and management to nurse leaders, physicians, and pharmacists for a number of years, about 15 years now. I've been teaching leadership, including at University of West London, and trying to understand how it's not just clinical. It's not just our best intentions that we want to care for people, but we actually have to teach people to understand how to recognize what's not working and take some responsibility for that, whether or not they have the authority or think they're the leader, that they take a role of participating in making service delivery work. And so out of the research that I did while I was in London, I really bring that back into my practice as I work with nurse leaders within the hospital system and with nursing students. We actually teach management to undergraduate nurses in the US. They have a clinical rotation where they do not touch patients. They actually are paired with nurse leaders close to the top of the food chain, and they have to look at things like quality improvement or diversity or problems that are happening with leadership or with the workforce or people who are coming late or policies that aren't working. And it helps to schedule those kinds of exchanges, that you can't build good relationships if no one ever teaches you how to build good relationships. And what I talked about on Tuesday was really about context and perspective and complexity, that what nurses are experiencing right now, the studies coming out of the US, and I think it's similar in the NHS, is incivility. And violence against healthcare workers is a huge problem, especially in the hospital settings. And so they're frustrated. They're leaving the profession. It's getting harder to recruit. It's getting harder to keep people in the profession. And so we need to give them those skills as we're growing them. how do you build good relationships when it's complex and it's hard and things aren't going well? Do we have to give them the skills to approach these complex situations and build bridges? So we offer opportunities to gain new perspective by putting them in a multiple in a lot of different settings across the hospital, and occasionally in the community. And one of my concerns in many of the places that I'm working, I'm also doing some consulting now in Nepal, is that the nursing model in Nepal is much like it is in the UK. Many nurses learn a lot about the hospital, but they don't actually learn about the community. But they have good skills for interacting with patients and interacting with patients' families. But without having that additional context to understanding that we only see them for a few days in the hospital and then they go back out into the community, we have to build through the educational models the ability to practice learning how to build those bridges, how to identify the barriers when you see them, how to proactively step into those gaps in services and say, I could bridge that. It is my job to understand that they may not understand that social work is the right group for them right now, not the surgeon. And so helping the nurses to build those bridges means that they can help build that sense of community as the patient leaves the hospital and comes back in. So identifying areas that benefit from working together is often the product of co-design. And I feel good about what the work we're doing at the University of Michigan right now with our undergraduate nurses, helping them to identify 6-week projects that they actually approach some kind of change and build some solutions to gaps in services, but it's only in the hospital setting. And I'd really like to extend that out into the larger community. My body of theoretical work is usually around the term boundary spanner, which comes out of the management literature in the late 60s and early 70s. And boundary spanners, much like myself as a nurse practitioner, and people who are on this call today, speak multiple languages. We can break out of our silos and say, what if you connected with them over there? We might be able to do something new. That area on the margins between one organization and another is messy. And it's not always easy to understand how another organization, another institution, another policy is working, unless you find ways to break out of your usual way of being. But I really believe that we can actually create these gated channels, and we can try new ways of communicating, some which are just being in the same room at the same time, like I saw happen with the South Hall project and the work that you were doing, Paul. People sat in the room, and I remember the day an endocrinologist who kept showing up and never opened his mouth, a year and a half in, looked up from his BlackBerry and said, and started having some good ideas. And so how we move participation to, just observation, to participation, to thinking out of the box, to trying to find new solutions, we can practice that. And it's not just something we can put on a syllabus. We have to actually try to do it. Part of what I published coming out of that work with Paul's help was, and actually Jerry McGivern was in the room on Tuesday, and I had worked on some of this together. Business school included people from other schools, not just nursing, not just medicine, but also the community base and others, to look at whole systems of care. What interests me in this idea of participatory action and evaluating as you go, creating the evaluation cycles as you develop them, is that it's a lot of hard work. And I think of that as whole systems of care. I think most of you on this call think of that as whole systems of care. What was interesting to me and keeps happening is that when I was getting ready to present this in Montreal, they assigned me with the systems group of talks, which included computer systems and using AI and all the other kinds of things that had nothing to do with humans. And it was quite confusing for the audience to think of boundary spanning as a human act of building relationships and not just technology. My department that I'm in at the University of Michigan is the Department of Systems, Populations, and Leadership. And we actually have a lot of computer engineers in my program. And I'm, again, struggling to build this idea that when we talk about whole systems of care and health systems, we actually think of systems thinking in my world, in primary care world, in community-oriented integrated practice world, as relationship building, which is not the same as a computer network. So I think we have some way to go there, that by structuring these opportunities, putting real people in real rooms at the same time and teaching them what we've always taught them, which is to listen and touch and be with somebody, experience the complexity of their lives, hear them and gain perspective, challenge your own assumptions. That's when people grow and change. And by modeling that I can grow and change, and respect the differences of the people I work with, that my students can do that too. That gaining perspective isn't something that we expect students to do, but then we stop doing it later in her career, but that it's actually a part of our entire way of being and practicing for our entire lifespan as humans, that as you move and question your own assumptions, you're a more agile, reflective practitioner, and that's really what's going to make the difference. What interested me when I made this presentation in Montreal was that many of you might have heard of Simon Sinek, who talks about leadership. And he was the keynote speaker. And he said to a room of 10,000 nurses, his books are incredibly popular. It's a shame they don't teach leadership to nurses. And I just was really upset because we've been teaching leadership to nurses, and I now teach policy to nurses and to physicians and to social workers. And it's really about the opportunity that David referred to, these windows of opportunity that they open and they close. And anybody who wants to make an impact and change both an individual's life as well as a community's life has to recognize those opportunities. And to recognize the opportunities, you have to see the margins. And to see the margins, you have to question your own assumptions. And to question your own assumptions means that you're going to be uncomfortable a lot of the time. And if I can do anything to help my students in this country or that country to just question their assumptions as a matter of how they practice, then maybe we have a chance to recognize the opportunities for impact.
One of the issues that came out on one of the tables on Tuesday was how we have to institutionalize learners, that's from school children to retirement age people, to explore uncomfortable things routinely. Now, we don't particularly want to give medical students a near-death experience every year, but we can get them to explore something that is outside of their normal comfort area and a sort of supported kind of environment. And that exactly happened for me when my wife was sick. The school had loads of kids who were helpful. They came along and they experienced my wife dying by being part of it. Well, it was actually not only dead easy to organize, sorry, bad word, difficult to organize. It was just a very, very wonderful community development opportunity. Well, look, this can happen all over the place because 1 in 10 of the population is a carer. Every sort of third house in a street has got something like this going on. So that's really possible. And that came out of one of the tables on Tuesday.
I think it's fascinating, actually. My understanding, very limited understanding of the kind of systems, the health and medical systems in the US is that it's very clinically led. From a social work perspective in the UK, having worked here for 23 years, it's very government led. It's top down, very hierarchical, reflecting the NHS structures, in fact. And the NHS has been developed over years on a very command and control philosophy, I would say. And it has its advantages. For instance, when you look at COVID and the public health reaction to that and the response to that has been very, very well received on the whole. It's very consistent, the messaging from top to bottom, to top to the front line. we didn't always get it right, of course, and we've had incidences of people dying in nursing care, nursing homes, etc. And I think that's because of a failure at the top to listen to the grassroots. If, for instance, policymakers had listened to managers in nursing care, or even indeed managers in social work departments throughout the country about discharges and the consequences of discharging people into homes that are not prepared for the pandemic, then perhaps we could have arrested some of the deaths. We've got a very well organised, very well fine-tuned NHS service, and also a reflection of that is a very well organised local government service that has been, how should I say it, been cut back through years of austerity now, decades of austerity. There's no fats left in the system. We are very used to change, and we are very used to responding to change. However, I think that what we're not very good at over the years is listening to our communities. And that's why it excites me as a social worker, because I started out as a community development social worker in Melbourne, Australia. And I can see that through community empowerment and community coming together, that you can actually create something very special. The organisation I used to work with, and still is there in Melbourne when I visited in April of this year in my hometown, was called the Australian Vietnamese Women's Welfare Association. It was founded in the 1980s by a very few Vietnamese women who were, I suppose, victims of a very patriarchal society. We were all the early refugees in Australia of the Vietnam War, and we were fleeing communist Vietnam at the time in boats. We settled in Australia in the 1980s. I was one of the first refugees. And there was a real need for communities to come together at the time, but in particular women, to mobilize their rights, really. Having landed in a new country that actually supports human rights and women's rights, a few of them got together. One of them was Cam Nguyen, who is the CEO, who was my boss at the time. In 2000, in the 2000s, early 2000s. That organization, when I left it, it was an organization of 14 staff members. This year, when I came back, they are employing over 400 staff members. When I left, we were trying to get funding from governments, both federal and state government, and it was. I think our turnover was about 140,000, something like that. Very, very, very little. Now it's over 40. It's over 4 million. So it has grown a lot, and through the years it's grown because of communities coming together, volunteers coming together, and people who believe in that community ethos. And it's not serving just the Vietnamese community, it's serving emerging communities as well. And that's the Somali communities, the African communities who have migrated to Australia and decided to settle in Melbourne. They don't always, support Vietnamese kind of social events and things like that. It's actually the kinds of funding that they receive and the kind of services that they provide are very much what I would regard as integrated care. It may not be so much delivered by GP. There's always GPs around. It's delivered by people on the ground who can talk about healthcare, who can talk about diabetes, who can try to support people to get a test who can link people up to not only their GP, but nurses and, maternity units and various programs that they run, and other agencies. And I think that's what integrated care means for me. It's not hospital based or institutional based. Integrated care, I think, is about care in the community. It's about relationships. It's about people taking on, that leadership, I suppose. So Laura, when you talk about leadership, for me, it's not leadership in the sense of managerial leadership, although that may be where a lot of the literature is derived from. I think that leadership is about community leadership, and I think that's where we've got a lot to learn. And looking back into that lovely presentation by Matthew Harris that we attended, there's a lot of leadership there. We don't always recognize it as that managerial type of leadership, but it's leadership from the community. It's people who take on responsibility for what they believe in and support their communities and choose to remain there, to choose to work in the messiness of it. So that's my reflection, really. I've in my 23 years as a social worker, I've come back around to the place where I feel that social work should belong. It should belong in communities and not with, government institutions. I think we've lost a lot through the last 20 years and even 30 years where, community care had replaced, real social work practice grounded in community practice. Community development is actually coming back now. And I'm really glad to hear that. I'd like to see more community development programs in social work, and perhaps there are opportunities for that in other professions as well, including nursing. That in terms of the digital aspect of it, I do think that digital does provide a lot of promise, and it can offer an opportunity for people to bypass that snobby professionalism that social workers often have. I think there's a fear of control or loss of control when people are given the information and information about their rights, their responsibilities under the Care Act or the Mental Capacity Act or Mental Health Act or Human Rights Act, etc. If people are given those information and they are supported to understand them, they can exercise them. They can challenge some of the so-called professional opinion, and I think that's healthy. It's healthy for us to actually listen to where people are coming from and understand, that perhaps our reality is not the only one, and that it challenges us to work in different ways, and that's where we are now as we I suppose look forward to the NHS 10-year plan of more community-based services, integrated neighbourhood services. We need to prepare our workforce for that, and starting with the very basics that maybe we've lost.
Carl Wake talks very well about leadership as sense-making. If you can understand how it all works, it makes sense to you, you can find your way to engage in it. If you're merely following somebody else's lead, well, the moment they go around the corner, you're lost.
Yeah.
So it would be good to shout loud about that wherever we can.
I just wanted to draw attention to what Matt did say on Tuesday, and also what came from the table where John and Duke were. This idea of the community health worker being measured against the goals that the clients in the community set, and then being able to reach their own goals, which was different than the professional goals, so that the community health worker wouldn't be judged against being less than this kind of worker. And I'm seeing some of the same hope to try to figure out how a community health worker can be judged as worthy, or that we can understand and measure if they can reach their outcomes. But in a lot of settings, you have, a lot of different kinds of people who go into the home and have a different set of skills, and they're not less of a nurse or less of a doctor or less of a GP. We actually need people who specialize in understanding the community and connecting to the community and setting goals that make sense from the community's point of view, and hearing that. And that came through loud and clear in Matt's presentation. And it was really helpful for me to hear that, and to hear it again from you, Duke, that we get used to clinical outcomes being set in this certain kind of way, and then we silo our professions out, and then we decide who the leader is within that. And I've been working as hard as I can to say, what does influence and connection look like when it's not you're in charge and your title and your profession fit a certain box?
One of the things that came over very strongly is this building of systematic, that something has to be put in that's somewhat systematic, because what I've seen over time, and in this forum, there is excellent practice going on, the sorts of things that you're describing, Laura, the sorts of things that Duke's talking about. But the problem is that if you don't have the system supporting it, then it doesn't flow out and doesn't continue. I think there's something about systematically recognizing the values that you're describing in a way. I certainly, at the table I was at, which was supposed to be educationists, we were talking about getting upstream with students, so that they think differently when they come into practice, that they have a more open mind, and they're aware of the need of listening to patients and families and understanding things from that perspective. So I think there's something about changing the way we teach and the way we get students to learn in a community environment, which is building collaboration takes time, but if you do it, it makes a huge difference.
Laura talked about boundary spanners being people who speak multiple languages. I think the difficulty is that the whole direction of travel has been in the direction of greater specialization. And as a result of that, people do end up speaking only one language, the language of their speciality. And often people who are boundary spanners are looked at with some suspicion. They're seen as being jack of all trades and master of none. So I think we need to try to find a way of shifting that kind of mentality, and perhaps moving upstream, as you suggested, Linda, is one way to do that.
That point came out very well on the tables, actually, about the need to talk about generalism with confidence.
I absolutely think it's education, and it's as early as possible, which is why we really try to include as much health and environmental issues in our intergenerational public schools for youngsters. So I think although education takes time, trust takes time, it's where we need to go. The Lancet has this huge planetary health initiative. I work with the Hopkins group. They moved from Harvard to Hopkins. Yes, we need to take that global perspective, but I really think it's Mother Nature in our own community. And if I could say, not just human-defined communities, it has to be ecologically defined communities. It has to be what we call internationally bioregions, because quite frankly, collapse is going to occur. It's already occurring. Jem Bell thinks it started in 2016. Others believe it started earlier. We're on a downward trajectory with regards to the systems that we're all part of. So if we don't in this initiative value communities, because those are going to be the locus where we will have to keep our health going, because the system around it is collapsing and is going to continue to collapse.
And of course, ecological communities are communities that are developed rather than already sort of thought to exist. So the whole notion of living life forward in the complex, messy thing, rather than accepting some kind of mythical truth of the past, is part of what we've been talking about for a long time.
The King's Fund used to talk about boundary spanning some time ago. But one of the issues for us when we choose our formal leaders is we tend to pick a type that is strong and top down and technically good, rather than these personal attributes. And I've been saying for some time to various people, including the ones I've just written to a couple of politicians, is we have to make a serious attempt to look at how we choose our leaders on their personal attributes together with their technical skills, because in the health service we tend not to. And as a further reflection, we all might agree with that, because they should be better and be of this type, but I wonder if we do the same. So there's a lot of interest, we say all these things, but when we, in our actions, do we actually choose those people who can keep in sort of control of situation by letting go? And generally we don't. So I think we have to be honest about ourselves as well when we criticize those in senior positions.
So one thing we've never focused on in COIN is Cuba, which I think has a long track record of picking people who are likely looking health carers and nurturing them to become local leaders. They're from the local communities. They think about the breadth of skills as well as the medical skills. And of course, Jerry McGiffin was quite interestingly there on Tuesday from the King's Business School. And he teaches this kind of leadership as broad-based, humble, leading from the back kind of stuff.
And sometimes we get this tension, which is essentially the use of the community to support the individual against using the individual to support the community. And so there's this idea that when you think about community assets, are you looking at the things that are essentially exploited by the health beast to the benefit of its own ends? Or are you looking at things you actively support and grow and kind of develop? And I think you need a balance, because there's an awful lot of assets in communities that can absolutely benefit the individual to achieve what they want to kind of achieve. But at the same time, unless you are putting in investment to grow and develop those kind of community assets and not just focus on utilizing them to support the individual, you eventually erode them over time, and that can be quite damaging. The other one that occurred to me when we were just talking about technology and digital is and I can't remember who invented the term, but the danger of teaching the eye patient as opposed to the real patient. And this tension between, and again, this comes very much for the teaching. Do we start teaching medics or professionals or whatever to essentially see a range of diagnostic kind of tools and a AI sort of thing, and that is what we treat, versus the relationship with the patient and the individual and the things that maybe our stats and data don't tell us. And I think the third point was alongside that, teaching about how to build relationships, teaching about how to navigate the system and understand how and where decisions are kind of made, because again, one of the conversations on Tuesday was very, very much, an understanding of what actually motivates a commissioner to make a decision, and then what is the basis of that decision, and who actually makes those decisions as a necessary lever to bring about change or improved care outcomes.
People need to be exposed to complexity and difficult things in safe kind of ways. Well, that can be done right from preschool and school and medical school training all the way through. If you simply help people to learn facts one by one, they're only going to believe that the world works in things one by one. But we could advocate in neighbourhoods right now this more complex, multidisciplinary exposure to the messiness of life.
I'm the chief exec of Primary Care Commissioning, which is a community interest company. So we're not for profit. We do need to make sure that we bring in enough income to, of course, cover our costs. But we work across health and care. We actually do work across the wider public sector as well. Anything we do to benefit the NHS, and we try to plough benefit back in through basically disseminating and sharing information. And for that, we have NHS Networks, which is a site that we don't overtly brand with PCC, and we allow networks of interest to have web space on there and be able to put short blogs, put news items, the way we like to do it, because we don't like to nick anyone's IP or copyright, is we would much prefer to link to people's articles that are on existing sites, YouTube, publish elsewhere, but with a paragraph so we can push it out in newsletters saying what it is. So I have offered my comms manager to help to get you started on creating a network, and I am very happy to use our newsletter channels, both on the NHS network side and the PCC side, to push out information. PCC has supported primary care development since our inception, which was we incorporated in 2009, and since then we push out newsletters on a weekly basis and then have longer articles that go as well, to an audience of, at the moment, it's about 40,000 a week across health and care. So we have one newsletter focused on ICBs, one focused on practices and PCNs, and then one that is generalist across all health and social care. What we also do is we run around 300 events a year. That could be on request workshops. It is sometimes large national conferences. We ran one the other week for 3,000 people, which was commissioned by a public sector organisation. But we usually work with smaller gatherings of people who are interested in specific areas. And one of those areas that we're starting to work on is neighbourhood development. So it feels almost like the right time if we could push some of the information and some of your learning out. The other things we do, apart from supporting primary care, is we have leadership support. So we have worked to develop significant numbers of nurses, particularly global majority nurses. We have women in leadership programs. We do quite a lot of work with those groups that may be working in the health service who are disadvantaged. And we also work with GP fellows, GP trainees, and we've run a number of programs for them. All of this work obviously needs to be commissioned, but the important bit is quite a few of those people then start to join our mailing lists, which would then mean that we could get word out to them about what COIN is doing, etc. So
if we can, through your 40,000 communications a week and your 300 workshops a year, make it look just absolutely normal that community-oriented integrated practice is a thing that is needed inside effective neighbourhoods, that incorporates the things that we've been saying things today, that would be the most valuable contribution to just making it seem absolutely barn, because this is barn door obvious. Anyone in any real life situation knows that this is true, and that the what Duke was saying is also true, that if you just control things from the centre, then you just mess things up about the next stage. And I have to say, James Kingston, you've come in on split-second perfect timing, because you're another key person for COIN's future. You oversee the Complete Care Community Programme with 65 primary care networks that are going to become neighbourhoods pretty soon. And it seems to me that they're also likely to be places that could enjoy and benefit from the kind of things we're talking about leadership inside with the ideas of community-oriented integrated practice.
A career that spans more than 40 years in the NHS, 32 of which was in general practice. I say was because I've now stepped down from clinical practice. It seems though just recently, but it's quite a few years ago, but have continued with a range of projects and programs over the last few years, which ranges from networking, a national digital forum for the quality improvement and safety of online services. It's in the independent sector too, as you say, the Complete Care Community Programme.
Hi, my name's Hattie. This is my first COIN meeting. I run and organise a CIC called Body Talks Movement, which brings works with children in state schools, and and I run it internationally as well. But it brings children together through movement. But it also, we're working with SENS children. We're running it at Blossom House School this autumn, and developing that side of it as well. So it's something that could be run as a palliative care creative health program. It's shown that it really reduces the anxiety in children, and it helps with school avoidance. It can help children who are really nervous of going to school to feel more comfortable as well. So it's still in development. It's still early days. We developed the CIC in 2022. So, but it's getting more and more robust. We've just recently finished a case study, and it's getting ready to go out there into the world.
My guess, Hattie, is that some of the ideas about how children develop, and what we're talking about, how carers develop, how people develop, how schools develop, how health develops, are actually relatively similar, helping people to be comfortable inside their skin and move forward despite difficult circumstances.
Yes. I think that if the children from an early age can feel comfortable expressing themselves, that's and also it helps build healthy relationships as well. So we just recently also ran it with young carers who have to look after their parents or their siblings, and lots of them are quite isolated because of that, and they responded really well.
I want to ask you, Hattie, what's your take on children's abilities to handle really difficult things, let's say death, compared with adults, and how one thinks about those?
Well, we're actually going to be running it with children who are taking part in talking therapy because of bereavement from January for the whole spring term. So I'll know more about that from a first-hand experience. But I imagine that it's the atmosphere around the children that matters, that the atmosphere around the death that matters, that affects them. And if they feel supported, then and listened to, then I think that will really help them. I also think if they can have an outlet to express themselves, that would be really helpful too.
My own view is that children quite often, they consider whatever they're experiencing to be normal. They don't actually think there's anything to hide away or run away from. It's just this is what life is like. So if they can be helped to face up to that with support and comfort, then can be really good. I'm thinking that if you help people to feel comfortable with whatever difficulties they're going in, then actually they are the leaders of the future. And if we can expose everyone to difficult situations.
Yes, and actually, I worked with psychologists, and one of the studies that they did was showing children in kind of disaster zones or war zones connecting through various expressive arts programs. They feel a real kind of reassurance in seeing that there's other children or young people out there going through the same thing, and connecting through some expressive form can be really helpful and stop you feeling isolated or like there's something wrong with you. Or
first, as a governor of a school, I'm delighted about what you're doing, Hattie, and I know the issues are becoming more and more apparent around young people's mental health and well-being, so be interested to hear more about it.
A lot more that we can learn from the communities than the communities learning from us. And rather than maybe celebrating by way of a conference like an NHS Confederation conference about what we do best, let's learn from the communities themselves. I think there's a lot to learn from communities across the world in how they address inequalities, as well as in urban communities in London, Melbourne, San Francisco, etc. And perhaps that's where COIN could really make a difference. This group can really make a difference about it, but it's about reimagining the culture, not replicating the language that we use in the NHS or the language that we use in councils when we look at our communities, when we work with our communities. We should listen more and learn from them. And
just to celebrate listening to communities, but also the role of children and elders, because children and elders are often forgotten. But just as Hattie was leading us in the conversation about how children are more natural systems thinkers than adults. They haven't learned adult categories, and older people have learned to be suspicious of them. So I do think that programming that brings younger people together in communities are really important.
Laura attended the inaugural meeting of what we've called the Global Alliance of Primary Healthcare, and had colleagues from US, Singapore, Nepal on the call. So, and Paul, you did have sight of the position statement. Too much to talk about it, but just to say it looks as though we've got momentum behind it, and a couple of governments who want in as well. Well, Laura's nodding, so that's full endorsement then. So
let's close this part, and thank you for being here today, and thank you for being here all those months, years, and decades in some instances. We have a window of opportunity where in the next year or maybe 2 years we can really make a very, very significant difference by building on the strength of this last year. And we need people to join in with that. So for now, happy summer for those of you who are in the Northern Hemisphere. And we'll see you in September, and plenty of behind the scenes writing and communicating.